Bueno, muchas gracias. Yo también quisiera darle las gracias a los organizadores. Esta es una continuación de la presentación que inició el doctor Zapata. Ahorita les estoy hablando en español, pero la presentación va a ser en inglés, y la razón es porque cuando presentamos sobre la frontera, Estados Unidos-México, la cultura en la frontera es de presentar dos personas cuando se habla de un proyecto o proyectos de la frontera, uno del lado mexicano y uno del lado de Estados Unidos, y obviamente se presenta en inglés y en español, aunque yo quise presentarlo en español hoy, solo para practicar el español. También le quiero dar las gracias al doctor Zapata porque de un día para el otro decidió, o mejor dicho, lo forzamos un poquito, pero se integró a la conferencia y les pudo dar la ponencia que iba a dar la doctora Rangel. Aunque creo que le vamos a tener que dar una poquita de mentoría porque si sigue diciendo que sí a todo, le va a afectar su salud. Bueno, entonces, voy a presentar en inglés. So, what I'm going to present as a continuation of this presentation that Dr. Zapata initiated with is to talk about an intervention that's community-based. And it's an intervention that is actually part of a broader initiative that is part of the Global Centers of Excellence that are funded by the National Institutes of Health and an insurance company, United Healthcare. And so in integrating ourselves into these 11 centers, as you can see in the map there, the 11 centers actually have partnered with academic institutions in the U.S. and academic institutions in those parts of the world that you see there on the map. So for Mexico, the collaboration is between El Colegio de Sonora and the University of Arizona. And in coming together to participate in this project and this broader initiative, we created the Center for Health Promotion of Northern Mexico, which is it's based and housed at the Colegio de Sonora in Hermosillo, and in partnership with our Arizona Prevention Research Center at the College of Public Health and at the University of Arizona. And again, as part of the global network, Centers of Excellence funded by NIH and United Healthcare. The initial funding for our project came from United Healthcare and their chronic disease initiative. So just to provide a little bit of background about how we came to develop this intervention, we actually initiated with a scoping review, which is a little different from doing more of a Cochrane systematic review, in that we wanted to look at all of the literature, not just the scholarly literature, but also the gray literature. There are a lot of reports, a lot of very good peer-reviewed reports, peer-reviewed at the government level. And we identified, we initiated with something like almost 400 articles, and then we started to narrow that down further because we wanted to focus on heart disease, cardiovascular disease, the chronic diseases. And so that narrowed our scope down to about 44 articles. And then we narrowed it down further because we wanted to focus on the U.S.-Mexico border, and we wanted to also use these two evidence-based interventions that we use to adapt to develop the intervention that I'm going to talk about. So we ended up with 7 articles. All 7 articles were actually published on the U.S. side. The only thing we could find on the Mexican side were more reports, so more of the great literature, and more government reports coming from the federal level. The intervention that I'm going to talk about is actually an adaptation of Pasos Adelante, which is an intervention that was developed by the University of Arizona and was actually designed for a population on the U.S.-Mexico border on the U.S. side. So for about 6 years, this intervention was designed, was piloted, was implemented, and evaluated for about 6 years in the Douglas, Arizona area, which is Douglas. The sister state in Arizona is Sonora. and the sister city to Douglas is Agua Prieta. So this intervention that we use to adapt for purposes of adapting into a Mexican community or urban setting was actually with a population, a very small population, which Douglas is about, I want to say about anywhere from 50 to 60,000 people within the city itself. So as you can see, Pasos Adelante was recently recognized as an evidence-based intervention addressing CDC's winnable battles, which include physical activity, nutrition, and obesity. So our focus is really to design a community-based, not a clinic-based, intervention of health promotion based on social cognitive theory and a social ecological model. And I'm glad Dr. Elisa actually showed the social ecological model. Thank you very much. So prevention and health promotion programs led by community health workers, which is what I'm going to talk about, and we haven't really heard up to now, these are programs that have been led by community health workers or promotoras de salud or promotores de salud, because you have both men and women working in this field, that have shown to be very effective in decreasing risk factors for non-communicable diseases among the Hispanic population in the U.S., and in particular with people of Mexican origin. But it wasn't really clear if the results were applicable to other social and environmental contexts. I should reference here that community health workers in the U.S. have really emerged since the 1990s. And just recently, in 2009, the Department of Labor has recognized community health workers as part of the workforce. So it's classified now as a workforce or occupational workforce. So there are approximately 85,000 community health workers in the U.S. working within 6,300 health and social service organizations and agencies in all 50 states of the U.S. So we started looking at, once we did the scoping review, we started looking at Pasos Adelante and how we could adapt it to a more urban setting. And we wanted to do this in a very collaborative way. And so we included, they were actually part and parcel, the Secretaría de Salud, which is the Ministry of Health of the state of Sonora. We also included a regional advisory group made up of a variety, a very diverse group of stakeholders with interest in the topic, and of course the research team. And we then made several changes to the implementation protocol and changes to the program materials. Some of these changes included, which is very, very important, adapting it to the social standards, the Mexican norms and standards and the healthcare system of Mexico. And of course, cultural norms and regional language were just as important. Improving the graphic design, streamlining the content, increasing mental health and community health content, having a greater emphasis on the participative methodology, among other changes that were done to the program. And this was done in a very collaborative way. It was a very lengthy process. There were focus groups with a variety of stakeholders, just a very lengthy process, which involved a lot of community engagement, making sure that it was very inclusive. So it was a very lengthy process for us. So this intervention, which is very community-based, not in a clinic setting, although the community health workers that we use, or the promotores de salud that we use, were actually from the centros de salud, and I'll go into that a little further. But the name of the program is Meta Salud, and as you can see, salud in Spanish means health. Meta means goal or finish line, but it has a Greek prefix meaning overarching. So Meta Salud is more of a play on words, which literally means the goal is health, but it also implies change or transformation in a broader sense. So the method is a quasi-experimental pre-test, post-test study, which took place over 13 weeks with follow-up measures. Results in physiologic changes, anthropometric measures were also taken among a low-income participants. So the intervention actually took place, was implemented in 4 low-income neighborhoods in the city of Hermosillo between 2011 and 2012, and in areas surrounding health centers or community health centers that are sponsored and financed by the Secretaría de Salud, called Centros de Salud, and they're administered by the Ministry of Health of Sonora. And so, as I mentioned earlier, the Mexican state of Sonora is the sister state to Arizona, and Hermosillo is the capital of Sonora, and it's a medium-sized city of approximately just under 800,000 inhabitants. And according to Mexico's most recent National Survey on Health and Nutrition, 18% of the Sonora population older than 20 years have hypertension, about 8% have diabetes, and 71% of men and 77% of women are overweight or obese. So as I mentioned, we trained approximately 20 community health workers or promotores de salud, but we had 9 of these individuals implement the intervention in these 4 neighborhoods. So this 9-week intervention, this 13-week intervention was implemented in Hermosillo, and excuse me for the 12 there, I made a mistake. It's 13 educational sessions, which included these topics. And it included a physical activity group, which was led by the community health workers initially, and they met once or twice or 3 times a week. After a while, after maybe 3-4 weeks, the community health worker didn't go out with the group, with the walking group in the neighborhood. And so we were looking for them to sort of take responsibility for undergoing the physical activity part of the program. And I'll go quickly into some of the findings, and I'll give you the citation for the article that was just recently published on this study in September of this year. But quickly, some of the demographic findings include, and again, I made a mistake there with married. It's 98% women, mostly married, of low income, about 5 members per household. Average age was about 41 years, and a third were self-identified as migrants. So 87% of the individuals that participated had been living in Hermosillo less than 10 years. The educational level was 90% of the participants had less than a 12 years of education. This is a very busy graph, but this is just to show that some of the outcomes of the study and the statistical significance in decreases from baseline to conclusion of the program in body mass index, in waist circumference, in hip circumference, triglycerides, low-density lipoproteins. From baseline to 3-month follow-up, we observed statistical significant decreases in body mass index, HDL, LDL, and so the outcomes of MetaSalud were compared with the previous implementation of Pasos Adelante in Douglas, and we found very, very similar findings with some differences. I should mention that we never promoted this program as a weight loss program. And even with Pasos Adelante, we stayed away from this whole idea of dieting and weight loss, because that seems to be sort of like a 4-letter word on the border. So we never promoted this as a weight loss program. So some of the conclusions of what we found and what we achieved were these positive physiologic changes that were very comparable to the program or intervention that we adapted it from. And there's suggestions for scalability as an effective behavioral intervention for the U.S. and Mexico states, which share a very common boundary, as well as other regions with similar cultural and linguistic characteristics. Some of the next steps for us are scalability and sustainability. And it was by design that we worked with the Secretaría de Salud in Sonora, because that's a very good way of sustaining some of these evidence-based programs or interventions, because they can, given the fact that we use their promotores de salud, it's an easy transition to scale it up across the state in the jurisdictions or health districts within the state. There's also some very positive discussions with the Health Promotion Division at the federal level here in Mexico. And something that I'm very excited about is partnering with the Ventanillas de Salud. As some of you may know, and my colleagues from the states, if you look hard enough, you'll find a Ventanilla de Salud in your state. There are 50 of them. There's even one in Anchorage, Alaska. Just to show that folks from Mexico, our counterparts in Mexico, are all over the country, and actually all over the world, if you look close enough. So we're hoping that we can implement this within the Ventanillas de Salud in the very near future, and we're already preparing for some training with some of the Ventanillas along the border. So just final thoughts and conclusions. Every community has they have very specific challenges, and I think poverty has come up in several of the presentations, but especially along the border, there's poverty, there's low educational attainment. We found a very great need for mental health services during the study process and during the implementation of the program. Barriers that impede physical activity, personal. I mean, we have to think about people's priorities, and when people live in poverty, their main priority is food on the table. And of course, cultural and social factors that we have to take into consideration. But one of the things that we don't really think about are the climatic factors. And if you've ever been to Hermosillo in the summer, you can experience temperatures of greater than 115, 120 degrees Fahrenheit. And so to go out to do physical activity, that's quite a challenge. But also, and as Dr. Ewing talked about yesterday about the built environment, as you can see there, these are some of the conditions that people have to do exercise or even to recreate. So these are things that we have to consider in designing and in implementing interventions. And of course, participant retention is a big challenge, again, because it's a community-based intervention. We're not working with a captured population. So there are many factors that go into retaining participants. So incentives are very, very important. And many times you don't have the funding to be able to provide incentives to participants. And then just again, the importance of not to forget that advocacy and public policy development are part and parcel of these interventions. And you can actually, promotores de salud are actually very good advocates. And it's easy to train them because for the most part, when you work with promotores de salud, you're working with people that are from the community. They're already known and recognized leaders of the community. And so with a little bit more training, it's incredible the things that they can accomplish on their own and as a group collectively. And we have many examples along the border where promotores de salud have actually changed policy. Maybe it's at a very, very local level, but in fact they've been able to change policy, and that's been very empowering. So that sort of enhances their disposition to participate in keeping their communities healthy. And so this is the team, the research team that developed MetaSalud, and then this is a collage of some of the training sessions that we had with the promotores de salud. And I just want to thank you for your attention and for the invitation to be here with you and sharing this intervention with you. Thank you.